Hello, this is Mrs. Condry. This is problems of oxygenation for upper respiratory problems. Our learning outcomes, we will describe the nursing management of problems with the nose, sinuses, pharynx, and larynx. And you will learn how to manage a patient with a trach and a laryngectomy, and you will describe signs and symptoms of head and neck cancer. So upper respiratory problems include the nose and sinuses. A deviated septum is where the nasal septum is deflected, so it's not straight. It's usually caused by trauma, punch in the nose or something like that. Or it can actually be from drug abuse as well. Sniffing cocaine up the nose can alter the normally straight nasal septum. And so it can cause congestion, especially if someone has allergies. It can cause a lot of congestion, and sometimes they actually have to have surgery. The most common facial fracture is the nasal fracture, and if they have that, we need to assess for airway obstruction, a bloody nose, and leakage of cerebral spinal fluid. Now that would be very bad if you see it especially coming out of the ears or out of the nose. That is not good. A bloody nose is usually caused by trauma, hypertension, dryness, upper respiratory infections, allergies, sinusitis, foreign objects, kids stuff like peas and things up their nose. And the important thing is to keep the head elevated. And to lean forward. So most people think, oh, I lean back to stop a bloody nose, but that can cause obstruction in the throat. So you need to have them keep their head elevated but lean forward, pinch their nose for 10 to 15 minutes because that's putting pressure so it will stop bleeding. And if it doesn't stop bleeding, then the patient should go to the ER or some kind of urgent care where the doctor can pack it, cauterize it, or place a balloon if it just doesn't stop. And that can be more common with patients on blood thinners. So nursing management after nasal surgery, which includes like a nose job, which is rhinoplasty, septoplasty, nasal fracture reductions. For pre-op teaching, we need to teach them to stop their aspirin and NSAIDs prior to surgery and to encourage smoking cessation. So that's very important because nicotine decreases the oxygen available. Now, someone smokes, they may not, or they most likely will not stop smoking, but we do need to encourage it. Post-op, we need to monitor their airway and respiratory status. That's always the most important, airway and breathing. And we need to monitor their surgical site for swelling, keep the head up, use cold compresses on the nose, and avoid strenuous activities. That's really important. For them not to be trying to do anything strenuous, like even walking the dog. Sometimes people think, oh, it's, I'm just walking the dog, and as long as the dog is cooperative, that's one thing. But some dogs will chase after another dog, and they're holding back their dog, so it's important to avoid all those strenuous activities. Even a gallon of milk is 8 pounds, so they shouldn't lift like more than a half gallon of milk. Allergic rhinitis is a reaction of our nasal mucosa to an allergen. Allergen, yes. So the important thing is to identify that allergic trigger and avoid it if possible. Now, we can't avoid all triggers in this environment. So medications, which I'll go over more in pharmacology, it's important to take inhaled or oral corticosteroids before it really kicks in. So if if someone waits until their allergies are really bad and they can't breathe, it's not going to do as much as if they try to prevent that. So it's the first sign of allergic reaction. That's when they should start the inhaled corticosteroid, histamine blockers, and then decongestants, and the leukotriene receptor agonists. And those are a nice drug to prevent that allergic reaction, to try to mitigate those allergic reactions. And so that will be in Pharm, where I'll talk about that drug more. Viral rhinitis is the common cold, and is caused by more than 200 different viruses, and it usually resolves on its own with a typical recovery 7 to 10 days. The virus is spread by airborne droplets or direct hand contact, especially when people sneeze on their hand, touch a doorknob, and it can live on inanimate objects for 3 days, that virus. So we come along, open the door, touch our eye, scratch our nose, anything like that, we can pick up that virus. So important thing to do is to teach people to recognize the signs and symptoms of secondary bacterial infection. So often we get a cold, and then it puts us at risk for a secondary bacterial infection, which would include that elevated temperature, swollen glands, sinus or ear pain. So a sinus pain that can last for more than a week does require you to go to the doctor, and they actually do an x-ray of the sinus to see if there is a bacterial infection. And that, especially like my in-laws are a prime example. My mother-in-law got a cold. The next day she runs to the doctor. The doctor orders some antibiotics because she's old. She's 86, but an antibiotic is not going to work on a virus. And so that creates the resistance, the bacterial resistance, because so many people demand antibiotics. But if it is a secondary bacterial infection, yes, they can get antibiotics, but we need to relieve their symptoms, or teach patients to relieve their symptoms with rest, oral fluids, antipyretics like Tylenol, and analgesics. Again, that's Tylenol or an NSAID. Influenza is a different story. It's highly contagious. It's responsible for multiple deaths annually, and it can be more or less each year. And I just finished a book for my PhD program called The Great Influenza Pandemic, and it was written in 2018, but it was a pandemic that may have killed between 35 and 75 million people around the world from 1917 to 1918. What happened is, it's probably started here in the United States. We weren't stopping the transport of soldiers from one place to another, so it kept jumping from base to base and then to other people that lived off base. So it spread all around the world. And it was just the flu, but it was a very, very virulent strain. So from year to year, those strains change. So it is important to get the flu vaccine. I've always been resistant to flu vaccines until I read this book. And from now on, I'm just going to not complain when I get my flu vaccine. So the flu vaccine varies in effectiveness from year to year. And even though it may not be completely effective, it may decrease the virulence of that particular strain. So the difference between a cold and the flu, influenza, is that the flu has a very abrupt onset with signs of symptoms of fever, malaise, terrible aching pain, a headache, cough, sore throat, runny nose. All these things are very abrupt, whereas a cold just gradually comes on. So I just talked about the flu vaccine. There's the inactivated injection one and the live nasal one. But I think this year or last year they weren't giving the nasal one. I'm not it varies again from year to year. It's best if given early in the season, September or October. The rapid flu tests can differentiate influenza from other viral or bacterial infections. So if someone does have the flu, in that case, they should go to the doctor immediately to get a flu vaccine, and then they can get a drug called Tamiflu, which is the brand name, and it can help decrease the length. If you wait several days, at that point, it's not really going to do anything to prevent that flu from being so awful. So we need to treat with supportive care to prevent pneumonia, and that's why most of these people died in 1917 through 1918, because pneumonia was secondary, and then another reason was they had acute respiratory ARDS, respiratory disease, where the whole body's white blood cells and all the influenza fighters rushed to the lungs, and then the patient wasn't able to breathe because they weren't getting any oxygen at all. So the antivirals, which is the Tamiflu, may be effective if started within 48 hours of symptoms. So if it's the flu, it is worth teaching to go see the doctor immediately. For the cold, best to stay home and just rest. Sinusitis is a viral infection of the sinuses. Only 5 to 10% of patients with the viral sinusitis develop a bacterial infection requiring antibiotics. So that's why I said after a week, if it's still there, then you can go see the doctor for sinusitis, because it typically begins with within a week of an upper respiratory infection. So you get a cold, then you get acute sinusitis. We treat for symptom relief, and then after that week, if the symptoms worsen or last longer than that week, then you can see a doctor and may possibly get antibiotics. But it really should be after an x-ray. So there's a subacute sinusitis, and then there's chronic sinusitis. Chronic, it lasts longer than 8 weeks, and with repeated episodes of acute, and then they get loss of epithelium lining the sinus cavity. Those patients should be treated with antibiotics for 4 to 6 weeks because it is so difficult to cure. Management of acute pain and acute sinusitis is we have to manage those symptoms of the congestion, fever, malaise with antipyretics, NSAIDs, some histamine blockers. And patients with chronic sinusitis actually may need nasal endoscopic surgery to relieve that blockage, and they can actually blow up balloons inside the sinuses to help open up the sinuses. There's other infections that can occur with the pharynx, and that's two of them are acute pharyngitis. Acute pharyngitis is an acute inflammation of the pharyngeal walls. It's so hard to say all these words. Pharyngeal walls. And it actually can include the tonsils, the palate, and the uvula. And a virus is responsible for 90% of the cases. And the signs and symptoms are acute pain, severe red swollen pharynx, and they might have patchy exudate and a fever. So here's a picture of the pharyngitis. On the left is a picture of without abscess. Here, oops, I went the wrong way. A peritonsillar abscess is a complication of acute pharyngitis, and it's usually caused by this B hemolytic streptococci. It can threaten the airway, so it needs to be treated with IV antibiotics, an aspiration, drainage, and surgery if needed. So here is the abscess, so that can definitely threaten the airway. It can happen with children and adults, and so if someone's complaining of severe pain in their throat, it's worth taking a look at their throat. Problems of trachea in larynx. A airway obstruction is a medical emergency, of course. So the signs and symptoms depend on whether it's partial or complete. So if it's partial, you still can hear some sound, choking, stridor, nose flaring, wheezing. But if it's complete, they can't speak at all. That's the universal sign of choking. They'll get very red until they pass out. So we want to treat airway obstruction. So it could be a child who just swallowed a toy, and that would be, or a person who didn't chew their food and choked on their meat. That would be treated with the Heimlich maneuver. But then if it's, they may require, because that may not work, so they may go unresponsive. We call 911. The paramedics could do a cricothyroidectomy to open up that airway, an endotracheal intubation, or a tracheostomy. So that's why we are always careful about kids with children. I mean, kids with toys, small toys, are dangerous. But I know of this firefighter locally who choked on meat and died. He was a firefighter. He should have been able to fling himself over a chair. So if you're alone and you choke, you can actually put your rib cage over a chair to try to expel that. But he wasn't successful. Also because he was obese, and I think that was part of the problem, is that he wasn't able to expel it. So it can happen with adults too. So if you're choking, call 911 right away. It's an emergency. A tracheostomy is a surgically created opening in the trachea to establish airway, to bypass an upper airway obstruction, or facilitate removal of secretions, or for long-term mechanical ventilation. It's generally done in the OR, but it can be done emergently at bedside with a percutaneous tracheostomy. So if someone needs to be ventilated, say a patient with COPD has to be ventilated for surgery, the risk of that is that they aren't able to be extubated. And so if they weren't able to be extubated, or someone who needs that long-term mechanical ventilation, they would need to have a tracheostomy, because you can't just have that the endotracheal tube down forever. It's too much trauma. It's too dangerous for it to come out. So the nursing care of a tracheostomy is that the obturator post-insertion needs to be taped to the wall in case needs to be taped to the wall in case it falls out. I'm sorry. Okay, so the trach and intercannula, if present, needs to be cleaned at least every 8 to 12 hours. And if the trach is dislodged, it immediately needs to be replaced, as that hole can close very quickly. I had a student who was present. When that occurred, he ran and got the nurse. The nurse was able to place it back in before it closed up, and then, of course, respiratory was called. Head and neck cancer, most come from the squamous cells from the mucosal surfaces of head and neck. 85% of cases are from smoking. The signs and symptoms vary with the tumor location. A very early sign is hoarseness. So if hoarseness lasts more than a month, that's a sign that they may have the head and neck cancer beginning. So anytime a family member, anybody's complaining of hoarseness that has lasted a while, they need to go see their doctor. It can be a lesion in their mouth. It can be just sore throat. Later signs are problems chewing, swallowing, breathing, and weight loss, of course, because they aren't able to eat. A treatment for stage 1 and stage 2 is radiation or surgery. Stage 3 and 4 is surgery, radiation, chemo, and targeted therapy. It's very difficult. And usually they have a total laryngectomy with a tracheostomy. Radical neck surgeries usually require enteral feeding, so they have to have a feeding tube. They'll never be able to eat again. Quality of life really goes downhill. And that's the end of problems with upper respiratory problems.